All right, deep dive time. Imagine you're seeing a patient, okay? And they've got this, itchy, scaly rash on their feet. What's the first thing that pops into your head?
Yeah, for so many people, it's got to be athlete's foot, right?
Exactly. So today we are cracking open your revision notes. We're doing a proper deep dive specifically into Tinea Pedis. That's the medical term for athlete's foot.
Mm-hmm.
And we're pulling out all those high yield points from your material, the stuff you absolutely need to nail for revision, especially thinking about exams like the MSRA.
That's the plan. We've got your focus notes right here, and our job really is to walk through the essentials, sticking strictly to what you've already gathered.
Okay.
We'll cover it all, from the basic definition right through to, what can go wrong, the complications. The aim is to make you feel really solid on this super common condition.
Perfect. Think of it like we're just consolidating those key facts you've highlighted, no extra fluff, just the good stuff from the notes.
Precisely. Let's get into it.
Let's do it. So athlete's foot, let's unpack it.
Okay, starting with the absolute basics. The definition. Athlete's foot, or Tinea Pedis, it's a fungal infection. Specifically, it affects the skin on the feet.
Right. Fungal. Feet.
And the culprits. They're a group of fungi called Dermatophytes. Within that group, the ones from the Trichophyton genus, they're the most common cause you'll see.
Trichophyton. Got it. And it doesn't always look the same, does it? The notes mention different subtypes.
That's a key point, yeah.
Yeah.
It can present differently depending on the subtype. And just to zoom out for a second, Tinea Pedis is part of this bigger family of infections called dermatophytosis, or just tinea.
Ah, okay.
That term covers any fungal infection caused by these dermatophytes, like epidermophyton, microsporum, and our friend Trichophyton.
What makes them special?
They have this knack for invading dead keratin, the protein that makes up our skin, hair, and nails.
Ah, so that's the connection. And why people sometimes call it ringworm, even though there's no worm.
Exactly. It's purely down to the appearance of some tinea rashes, those ring-like shapes. Nothing to do with worms. And your notes rightly point out that treatment often hinges on where the infection is.
Location, 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 even for fungus.
Pretty much. It affects the look and the management plan.
Okay, so drilling down to the why, the etiology, the notes are clear. It's these dermatophyte fungi, especially Trichophyton.
Yep, they are the main players causing the infection itself.
But what makes one person get it and not another? Let's talk risk factors. What do the notes highlight?
Okay, several things make someone more prone. Warm, humid environment, sunshine. Just love that. Think sweaty trainers, changing rooms.
Uh-huh.
Then there's close contact with contaminated surfaces, damp floors, shared towels, that sort of thing. Big transmission route.
Right, the communal shower scenario.
Exactly. And importantly, a weakened immune system. If your body's defenses are down, it's harder to fight off the fungus.
Those seem like the big three. Really key for revision. Maybe a quick way to remember them.
Let's see. Warm and humid environments. Close contact, weakened immunity.
How about WIC? W for warm, I for infected contact, C for compromised immunity.
WIC. I like it. Yeah, that works. Warm, infected contact, compromised.
No.
Nice and simple. Covers the main risks.
Cool. So WIC it is. Now, how does it actually work? The pathophysiology, how does the infection take hold?
So the notes explain the fungi basically set up shop in the dead outer layers of the skin. That's stratum, corneum. And like we said, they thrive where it's damp and warm.
And how does it jump from, say, a floor to a foot or person to person? The notes mention different transmission types, anthropophilic.
Right. Good pickup. Anthropophilic means it spreads person to person. Super common for Tinea Pedis, often indirectly, like from skin scales on a floor.
Okay.
Geophilic is from the soil, less common for feet. And zoophilic is from animals.
Ah, so you could get a tinea from a pet.
You could, yeah, though maybe less likely for Tinea Pedis specifically. The notes mention common culprits like Trichophyton rubrum, very anthropophilic, and Microsporum canis, which is often zoophilic, from cats and dogs.
Gotcha. And the notes also classify tinea by site, scalp, feet, hands, nails, body. Is that just context for understanding the different looks?
Exactly. The specific fungus plus the body site environment really dictates how it appears clinically, which leads us nicely into something absolutely critical, especially for exams, the differential diagnosis.
Yes, the what else could it be list. This is crucial, right? Because getting it wrong can cause problems.
Massively important. Your notes list several conditions that can mimic athlete's foot or other tinea infections. You need to know these.
Okay, lay them on me.
All right, you need to consider things like contact dermatitis, maybe from shoes or socks, psoriasis, particularly on the soles, other fungal infections like candida, or even distinguishing between different types of tinea.
Right.
Then there's eczema, pityriasis versicolor, though that usually affects the trunk more, and seborrheic dermatitis.
Wow, okay. That's a decent list. For revision, maybe it helps to group them. Like you've got inflammatory stuff, the dermatitis, eczema, psoriasis.
Yeah, good way to think about it.
Then other fungal things, candida, pityriasis, and just telling different tinea types apart. Knowing that list helps you avoid misdiagnosis.
Absolutely. Because mistaking tinea for, say, eczema and treating it incorrectly, well, we'll get to that pitfall.
Okay, but first, epidemiology. How common are we talking here?
Extremely common, affects all ages. But the notes point out an interesting split. Tinea pedis athlete's foot, much more common in adults.
Huh, why's that? More exposure, maybe? Communal showers, gyms?
Possibly, yeah. Whereas Tinea Pedis, the scalp infection, that's more a thing in children, and onychomycosis nail fungus, also very prevalent, especially in older adults.
Interesting distinctions. Okay, let's paint a picture. Clinical features. What does athlete's foot actually look and feel like?
The classic description is that itchy, red, peeling skin. Often kicks off between the toes, maybe the little ones, and can spread onto the soles.
Itching seems key.
Definitely. Itching, sometimes pain. The notes also mention scaling, cracking, sometimes even blistering. And occasionally an unpleasant smell, especially if it's quite macerated or damp.
Right. And zooming out again to general tinea symptoms from the notes.
Across different body sites, you might see a general rash, maybe nail discoloration if the nails are involved. Hair loss is a big one for Tinea Pedis in kids. And remember, complications like a secondary bacterial infection can add their own symptoms, more redness, warmth, maybe pus.
Nasty.
And the notes also flag it's common in contact sports players, sweaty feet, shared spaces again, and people who are immunocompromised.
Okay, now let's really focus on the examination findings for Tinea Pedis itself. Those subtypes you mentioned earlier are important for spotting it, right?
Crucial. Let's break them down. The most common is the interdigital type.
Between the toes.
Exactly.
Right.
Especially those outer web spaces, like between the fourth and fifth toes.
Yeah.
You see scaling, maceration, that soggy white look from moisture, and fissures, which are painful little cracks.
Ouch. Okay, interdigital, what's next?
The moccasin type. Think about the name.
Like the shoe.
Precisely. It's this pattern of scaling and redness, sometimes quite fine, that covers the sole and wraps around the sides and heel of the foot, like the foot's wearing a moccasin made of rash.
Okay, that's a really clear visual. Moccasin type. And the third one...
Vesicobulus type. This one features blisters.
Yeah.
Vesicles are small. Bullae are larger. They often pop up on the instep or the arch of the foot.
Blisters on the arches. Got it. Interdigital, moccasin, vesicobulus. Now, your notes have this really critical warning linked to these subtypes and the differentials about avoiding misdiagnosis and iatrogenic harm. This sounds like the big pitfall.
It absolutely is. This is super high yield. The danger highlighted is mistaking tinea, especially those interdigital or moccasin types that look dry and scaly for something like eczema or contact dermatitis.
And then treating it with?
Topical steroids, which is standard for dermatitis. But if it's actually fungus, the steroid suppresses the local inflammation. The redness and itch might calm down a bit.
That sounds good so far.
But it doesn't kill the fungus. In fact, it allows the fungus to grow more freely because the immune response is dampened, the appearance changes, it becomes less typical. This is called tinea incognito.
Incognito, like it's hiding.
Exactly. The steroids mask the classic fungal appearance. The rash might look less red, maybe less scaly, but it spreads or becomes pustular or just looks weird. It makes the diagnosis much harder later on while the fungus has been happily multiplying.
Wow. Okay, so tinea incognito, massive warning sign. Using steroids on fungus can hide it and make it worse. That's a key revision point. The notes also briefly list findings for other tinea sites, just for context.
Yeah, quickly. Tinea Pedis on the scalp, often hair loss with broken hairs, helps tell it apart from alopecia areata sometimes. Tinea incorporeum, nail fungus, you see nails lifting onycholysis, thickening, crumbling, discoloration. Classic fungal nail look.
Okay.
Tinea corporis, body ringworm, those typical angular, ring-shaped plaques, scaly raised edges, maybe clearing in the middle.
And tinea manuum on the hand.
Often goes with Tinea Pedis. Frequently just one hand, interestingly. Scaling, redness. And again, watch out for tinea incognito if steroids are used by mistake.
One hand? That's a good clue. Tinea cruris.
Groin area, jock hitch, more common in men. Reddish, scaly rash in the folds, often spares the scrotum, usually has that defined edge.
Right. And tinea barbi.
Beard area.
Yeah.
Redness, scaling, often pustules, can look like bacterial folliculitis sometimes. These just show the variety. But for feet, those three subtypes, interdigital, moccasin, vesicobulus, are key.
Got it. Okay, back to athlete's foot. How do we confirm it's definitely Tinea Pedis investigations?
Well, first step is always clinical evaluation. Good history, good look at the feet. But to be sure, the standard is skin scrapings.
Scrapings.
Yeah, you gently scrape some scale from the edge of the rash onto a microscope slide, add a drop of potassium hydroxide to dissolve the skin cells, and look for the fungal hyphae, those characteristic branching filaments.
So microscopy is key. Do you always need a fungal culture?
Notes suggest culture is more for tricky situations, like if it's really severe or the diagnosis is uncertain even after microscopy, or if it's just not getting better with standard treatment. Helps identify the exact species and sometimes check sensitivities.
Makes sense. What about swabs?
You might do a skin swab if you suspect a secondary bacterial infection on top of the fungus looking for pus, increased inflammation.
Okay. Any other methods mentioned?
Microscopy for the hyphae is the main one. UV light, a Wood's lamp, can sometimes help for certain scalp fungi, but not usually the common foot ones like Trichophyton rubrum. Biopsy is very rare, really only if it looks very strange or isn't responding at all.
Right. So clinical look plus scrapings for microscopy is the standard approach. Okay, we know what it is, why it happens, who gets it, what it looks like, and what it might be mistaken for, and how to confirm it. Now, the really practical bit, management. How do we treat it, according to your notes, thinking UK context?
Okay, notes break it down into prescribing and non-prescribing. Prescribing first. The absolute first-line treatment is a topical antifungal cream.
Any specific one?
Yeah, the main classes mentioned are the imidazoles, things like clotrimazole, miconazole, or terpenafine. Terpenafine tends to be fungicidal, kills the fungus, while imidazoles are fungistatic, stop it growing. Both are effective first-line options.
Topical first. What if it's really red and inflamed and itchy?
If there's significant inflammation, the notes say you can consider adding a mild potency topical steroid for a short time, maybe a week or so, alongside the antifungal. But you have to be really careful here, remembering the Tinea incognito risk. Be sure it's fungal first, or use a combined antifungal steroid cream cautiously.
Right, that warning bell again. When would you use oral antifungals? Tablets?
They're generally reserved for severe cases, really widespread Tinea Pedis, or if there's also nail fungus, onychomycosis that needs systemic treatment, or if topical therapy just hasn't worked after a decent trial.
Got it. Topical first, oral for severe nail-resistant cases, steroids only briefly and cautiously for inflammation. What about the non-prescribing stuff? Self-care, hygiene advice. Seems vital.
Absolutely crucial, both for clearing the infection and stopping it coming back. The advice listed includes change socks frequently, go for absorbent ones like cotton or wool.
Keep feet dry.
Yes, especially between the toes. Dry thoroughly after washing. Avoid shoes that make your feet sweat and don't breathe occlusive footwear. And wear something protective, like flip-flops in communal showers, pools, gyms.
Basic stuff, but easy to let slip.
Totally. Other hygiene points?
Yeah.
Keep the affected skin clean, dry, and cool if possible. Wear absorbent cotton clothing generally if prone to sweating. Try not to scratch hard, I know, but scratching damages the skin more and can spread it or let bacteria in.
And preventing spread.
Don't share towels, flannels, socks, shoes. Cover your feet in those communal wet areas. And the notes also say people can usually carry on with their normal activities.
Okay, let's recap management from the notes. Topical antifungals, imidazole or terbinafine, are go-to. Short course of mild steroid with antifungal if very inflamed, but be cautious. Tinea incognito. Oral antifungals for the tough cases. And crucially, all that self-care advice, keep dry, breathable shoes, protect feet in shared spaces, don't share towels.
Perfect summary.
Yeah.
And don't forget the note about referral if you're really not sure about the diagnosis. Better to get confirmation than treat the wrong thing.
Good point. So assuming we do all that right, what's the outlook? Prognosis?
Generally excellent, according to the notes. With the right treatment and sticking to those preventative hygiene measures, most cases clear up well.
And prevention is basically just continuing that good hygiene long term.
Pretty much. Good skin and nail care, trying to avoid feet staying damp for ages, clean absorbent socks, footwear that breathes. And there's that important link mentioned again. Treating Tinea Pedis properly helps prevent it spreading to the nails and causing onychomycosis.
Ah, yes, treat the feet to save the nails. High yield connection. Okay, last section. Complications. What can go wrong if it's ignored or managed poorly?
The #1 complication listed is secondary bacterial infection.
Because the skin's broken.
Exactly. Those cracks, fissures, soggy bits, they're perfect entry points for bacteria like Staphylococcus or Streptococcus.
Mm.
Can lead to cellulitis, which is a deeper skin infection, or impetigo.
Nasty. Anything else specific to cite?
For Tinea Pedis on the scalp, hair loss can be a complication, sometimes permanent scarring alopecia, if it's a severe inflammatory type.
Yeah.
For onychomycosis, the nail fungus, complications are often pain, discomfort, difficulty fitting shoes because the nails get thick and distorted.
Makes sense. What about scarring from Tinea Pedis itself?
Note say scarring on the feet skin is uncommon. If it happens, it's maybe more likely in darker skin types, but usually fades. Extensive scarring needing fancy treatment like lasers is rare.
Okay, so the big worry is secondary bacterial infection. Then hair loss for scalp, pain-y problems for nails, and scarring is rare.
That covers the main potential complications highlighted in the notes, yeah.
Right, think we've covered it. We've systematically gone through your revision notes on athlete's foot and related tinea. Definition, causes, WIC for risk factors, how it works, the lookalikes and the differential diagnosis, those crucial subtypes like moccasin and interdigital, investigations like scrapings, and the management topicals first. Orals for severe, hygiene is key, and that big warning about tinea incognito with steroids, plus prognosis and complications.
Hopefully running through it like this helps cement those high yield points for your revision, remembering those clinical patterns, knowing that differential list inside out, and understanding why you do or don't do certain things, like being cautious with steroids. That's what really counts.
Absolutely. You've definitely got this. Keep these points in mind. And next time you see those itchy, scaly feet, take that extra second. Is it definitely tinea? What subtype might it be? Could it be something else entirely? Getting that right is key.
And if you want more help consolidating topics like this for your revision, especially for the MSRA, check out passthemsra.com.
Yeah, great resource. And for extra practice questions to test yourself, freemsra.com is also really useful.
So that wraps up our deep dive into your Tinea notes.
Brilliant. Good luck with the revision.